Hello, everybody. I'm Dr. Mohammed Nishati Zada. I'm a neurologist and movement disorder specialist. I also have had the opportunity to coordinate and run a community stroke program. And so I'll be working with you all many of the days coming up. And so as always, please be very open about your feedback. We're always trying to make the course better. It's always limited, doing this online because of the pandemic, but we still think that this can be a useful opportunity to go over many of the neurology issues to help you prepare for your board exam. So without any further delay, I'm going to go ahead and start talking a little bit about stroke prevention. This talk is going to include some topics related to both ischemic and hemorrhagic stroke, but especially focusing on blood pressure goals in the setting of stroke. What are some of the different types of stroke, and then how can acute stroke management take place? Having been a neurologist now for over 13 years, it's been very interesting to see the dynamics of stroke statistics change. Now, most of the time, the American Heart Association updates their stroke statistics usually every 2 or 3 years because it takes a while for the data to be processed. And so we're having a little bit of a delay, especially with the pandemic going on, but the most recent statistics that we have that were updated in 2019 actually go back to 2016. But when I finished my neurology residency training, stroke was actually the number 3 cause of death. And over time, it's actually declined to become the number 5 cause of death in the United States, behind respiratory illness and infectious diseases, things like sepsis and acute infections in a hospital setting. But what has changed during this time is that even though people are still having lots of strokes, people are more likely to live with the deficits of their strokes. As many as 1 out of every 19 people who die of all causes, 1 out of 19 was due to stroke. 795,000 strokes per year. The vast majority of these, about 3/4, are first-time or new strokes. And then 1 out of 4 people who suffer a stroke have already had a previous stroke. 130,000 people die each year from stroke. Now, if you put that into context, we've seen statistics with deaths related to COVID-19. I mean, this is still a large number of people dying every year just from stroke. And 3 out of 4 patients will survive, but most will have deficits. If we look at some other numbers, approximately 1 out of 3 stroke survivors will suffer a second stroke within the next 5 years. We can't make the stroke risk 0, but we can do things to try to lower that risk with each patient. Every 40 seconds in the United States, someone experiences or suffers a stroke. Every 3 minutes and 45 seconds, someone dies. 1 out of every 19 people I mentioned dies from a stroke. Estimated $33 billion cost annually just for the healthcare and medical expenses. But then if you factor in that many people will lose productive years of earning potential, it's the number 1 cause of permanent disability. There's certainly many people in their 50s and 60s who are still working age who can no longer function or work to be gainfully employed because of their disabilities. The risk for stroke in Black people is almost twice that of white people. Stroke actually kills more than twice as many American women every year as breast cancer. Nearly 3/4 of all strokes occur in people over the age of 65, but the other 1/4 are younger people. The risk of having a stroke more than doubles each decade after the age of 55. So it's not linear, it's actually exponential. The impact of stroke will likely grow in the next 40 years, due mainly to the aging population and improved treatment, not only of heart disease, but I would also add cancer to that. As other medical conditions become controlled, stroke continues to be the type of event that happens through the complexities of multiple vascular risk factors, some of which are difficult to reduce. The medical costs of stroke are expected to triple over the next 9 or 10 years due to the aging population. Just the number of people the baby boomers and Generation Xers who are going to come of age and be in that 65 through 79 age range. Some other points I want to mention about racial disparity in stroke. Black people are more likely to suffer more extensive physical impairments in relation to the strokes that they suffer. They're also twice as likely to die when compared to white people. Some of the reasons for this, beyond access to care or systemic effects of racism, include uncontrolled medical comorbidities like hypertension, diabetes, obesity, smoking, even sickle cell anemia is a risk factor. Specifically, Mexican Americans, among other Latino and Latina people, are at an increased risk for all types of stroke and TIA, and at younger ages than people who are non-Latino. So this is separate from people who may be from Central America or other Latino or Latina populations. And then Spanish-speaking Latino people are less likely to know about stroke symptoms than English-speaking Latino people, Black people, and white people. So there are many layers and complexities to some of these differences in stroke. What about how people recuperate after a stroke? Well, only 10% of stroke survivors may recover almost completely. That's a very small number when you think about it. 25% may recover with minor impairments. Okay, so that's good. 40% may experience moderate to severe impairments that require special care. This is a large number when you think about the thousands of people that we're describing who end up suffering a stroke every year. 10% end up having so much impairment that they will require care either within a skilled care facility or some sort of other long-term care facility. And unfortunately, 15% die shortly after the stroke. And remember, though, that percentage is probably dropping with continued acute medical care, improvements in acute medical care. Transient ischemic attack, TIA. This is a brief episode of neurological dysfunction caused by focal brain or retinal ischemia, because it can also affect the eye. Usually the clinical symptoms last for a few minutes. The classic scenario is going to be somewhere between 5 to 15 minutes. There are certainly people who could have transient ischemic attack that last 30 minutes, 45 minutes, an hour. The old definition was actually less than 24 hours, which was a purely arbitrary number when you think about it, because if you're going beyond 5, 10, or 15 minutes, it's much more likely that the longer you have lack of oxygen and you have ischemia to these tissues, the more likely that some neurons, some brain cells, some retinal cells are going to die. And so usually even people who have 2 or 3 hours of deficits that make a full symptomatic recovery, when we look at neuroimaging, especially restricted diffusion on diffusion-weighted imaging sequences of a brain MRI, or the apparent diffusion coefficient, or ADC map, you can end up seeing that some neurons are affected by the ischemia, and that's actually a stroke. So this is why the most classic description is going to be somewhere between about 5 to 15 minutes, but you could have a TIA even lasting up to an hour or two. Usually when neurologists are seeing someone who has suffered a TIA, we're not actually witnessing the deficits firsthand. We're having to rely on a description of what happened because the symptoms were very temporary and they've completely resolved. I think most of us in neurology have had that experience where some patients will say, well, my doctor showed me or was telling me that when they ordered a brain MRI, my brain MRI showed numerous TIAs. Well, obviously those are areas of ischemia, even if they're chronic cerebral ischemia related to small vessel disease. And so those would be most consistent with stroke-like episodes, stroke-like findings rather than actually episodes which are temporary or transient. If you look at all the people who suffer TIAs, this is a strong warning that over the coming days, weeks, months, over the next year even, the risk of suffering further ischemic stroke is fairly high. And so depending on the numbers you look at and the studies that have been done, the risk of a severe or serious stroke within 1 year is 10%, but even within the first 2 days after a TIA, up to 1/2 of people may end up having a stroke because they have an acute process that actually could extend. When you have specific risk factors like language deficits or involving speech, motor weakness versus things like sensory or visual change, age more than 60, presence of diabetes mellitus, or having an episode that lasts more than 10 minutes, any of these or all of these together can be more predictive of early recurrence. And this is what we see when we look at various TIA rating scales like the ABCD2 or the ABCD3 scores, with or without carotid imaging. As I mentioned, true transient ischemic attacks are brief attacks, usually lasting for minutes. If you end up having a longer attack that's up to 24 hours, even if the symptoms resolve, usually you'll see areas of ischemic stroke on neuroimaging. With advancement in 3 Tesla MRI versus 1.5 Tesla, some of the subtleties of restricted diffusion are more sensitive at picking that up. And so brain MRI may end up picking up abnormalities in the majority of these people who have symptoms lasting more than 2 or 3 hours. If we look at people who suffer a TIA and we follow them for 3 months and see what happens to them. This was a study from 20 years ago, but it's very interesting because, as one might expect, they're at a higher risk of having more TIAs, either one or more, or suffering a stroke. But because some of the same risk factors involved in developing an ischemic stroke are also similar risk factors for heart disease, some people could end up having a cardiac event, even if they don't suffer a stroke or a recurrent TIA. And as you can see, a small number also end up dying from a variety of causes. Some of them, it could include dying from complications of a stroke. But when we think about a TIA, sometimes non-neurologists may say, well, this is just sort of temporary and I'm glad that they've made a good recovery. But we need to be thinking about the fact that they're at a higher risk of suffering a variety of events. And this is just another number, 5% within 48 hours could suffer stroke. I mentioned some of the independent risk factors on the other slide. So it's sort of well known that if we find a person who's suffering a TIA, that we should try to intervene acutely and reduce their risk as quickly as possible, especially when thinking about this 48-hour TIA or stroke risk being fairly high. But before the Oxfordshire study, this was sort of not assumed. And so they actually divided people into 2 groups in this study. They had over 300 patients within phase 1 who were, when they were evaluated for TIA, they were actually referred to an outpatient stroke clinic with the idea that once they come to the clinic, sit down, talk about risk factors for stroke, and they will begin the initial treatment plan, versus phase 2 were 289 patients where they had direct access to a stroke clinic and treatment on day 1, including things like antiplatelet agents or cholesterol lowering agents, for example. And so what they found in this study is that the results provided some evidence that if you followed people for 90 days, so you're looking at 3 months, that stroke risk was reduced by 80% with early treatment. This is fairly significant. Now, it didn't say, for example, how long the wait times were to get into clinic, but ultimately this is a fairly significant finding. And this is one of the reasons why, even when people are evaluated, for example, in an emergency department, usually an attempt is made to talk about and initiate antiplatelet therapy as soon as possible. I mentioned we would talk about different types of strokes. So if you look at embolic strokes, sometimes these are known as cerebral embolisms. And so the idea is that you have a type of clot. It could either be red clot